We'll now move straight on to our next speaker. We're really moving around the world this morning. Professor Philip Hazell is from Sydney and is the Professor of Child and Adolescent Psychiatry there, talking about a very important issue which certainly in my country we've realized recently has been significantly neglected, self-injury. Professor Hazell.
Thank you, Dr. Baxter, and good morning, everybody. My talk today is going to focus on self-injury. I have a number of declarations of interest, but none of them relate to the specific topic I'm speaking about today. I am going to begin by giving you a quick tutorial on some of the terminology that's used in this field because it can be a little confusing. That is because the terms overlap, and at different periods over the last decade or so, different terms have been used to describe the same thing. So non-suicidal self-injury refers to injury which is restricted to external injury and where there is no suicide intent. Deliberate self-harm is a term used in the US almost synonymously with self-injury, but elsewhere in Europe and in Asia refers to and is inclusive of internal injury such as ingestion and is agnostic about suicide intent. Parasuicide is the same as for deliberate self-harm, except the behaviour is aimed at realising change. That change may not be specifically harm, it may be to influence relationships. So there is some clear motivation behind the behaviour. Attempted suicide is a more specific subcategory of parasuicide, characterised by a strong intention to die. Then we have a range of terms which refer primarily to method, so self-poisoning, self-mutilation and so on. And then finally we have self-injurious behaviour. Sometimes this is used synonymously with self-injury, but in other settings it's more exclusively used to describe behaviour in populations of individuals with intellectual retardation or autism. At the end of the day, these behaviours occur on a continuum of medical seriousness and a related but not identical continuum of intent to die. And in fact, individuals may switch between these various categories of behaviour, and indeed it's quite possible for individuals to have several categories of behaviour simultaneously. For example, somebody who has a frequent self-injuring behaviour but in a period of crisis makes a suicide attempt. When we look at community samples, these are the kinds of behaviours that young people, aged 10 to 17, engage in. You're not going to see most of these people. Only about 1 in 10 ever get to clinical care. But you can see that self-battery of one kind or another is one of the more common kinds of self-harm, whereas cutting, burning and overdosing are relatively less common. The situation changes significantly, though, when we move into the clinical setting, where cutting moves way up the batting order and is the most common form of self-injury that we see in clinically referred populations. Self-battery is still up there with head banging, followed by medication overdose and other forms of self-injury or self-harm. Girls are more inclined to engage in cutting than boys. These are data from a predominantly European cross-sectional study of 15 and 16-year-olds. And the definition was self-harm, not self-injury, so it's agnostic to suicide intent, but cutting, more common in girls. In boys, we have a mixed category of other methods, and this was predominantly self-battery. About 1 in 10 of the individuals in this study who reported self-injury used more than one method. These are data from an Australian cross-sectional study looking at self-injury across the age span. What you can see is that self-injury gradually declines with age, and that for the most part self-injury is of roughly equivalent prevalence in males and females. And this is quite a distinction to the self-harm and attempted suicide data. The exception is in the age band 18 to 24, where there is a clear and obvious spike in self-injury amongst females. If we drill down into these data a little more closely, we find that the biggest spike in self-injury is in the late adolescent period, in the 15 to 19 age band. The gender ratio, these are self-harm data as opposed to self-injury data, where we expect a greater prevalence of self-harm in females than males. These again are from the European cross-sectional study. The rates are roughly 3 to 1 for males and females in most countries, but there are some exceptions. In Australia, the base rate of males was relatively low, so the ratio was more like 4 or 5 to 1. Repetition is common, affecting more than half the European sample. Cutting is the method that is more likely to result in repetition than other forms of self-injury. However, using the concept more than once is a little bit meaningless in the field of self-injury. These are data from a prospective treatment study of 12 to 16-year-olds that we conducted in Australia. It's reporting on 5 individuals in the study, and it's reporting on whether they did or did not engage in self-injury in each successive month that they were enrolled in the study. So yes, they did, no, they didn't. 999 refers to missing data. What I was attempting to do was to, during this 12-month window, categorise different patterns of self-injury. So the top individual is someone who has an intermittent pattern. So yes, there are some months when this person is injuring and other months when they're not, but it is clearly continuing right through to the end of the 12-month period. The next 2 individuals have what I call attenuating patterns. The first individual, NC22, has no further self-harm throughout the 12-month period. The second individual continues to self-injure for the first 4 or 5 months and then ceases the behaviour. The last 2 individuals in this slide have what I call the persistent pattern. So they are self-injuring most of the time, but there are maybe a few months here and there where they don't engage in the behaviour. The natural history of self-injury is somewhat vague. It's based largely on retrospective data, so we're not entirely sure about its accuracy, but it's thought that self-injury begins at around about 12 to 14 years. Its course is variable, but in most individuals it's ceased within about 5 years of starting. But you can see now that more than once is a bit of a meaningless concept. This in many individuals is quite a protracted and persistent pattern of behaviour. Why do they do it? Well, these are data from, again, an Australian cross-sectional study of young people who self-injured. Punishing self, managing emotions and reminding myself I'm alive were some of the more common reasons. Avoiding suicide, less frequent. Getting a high, low prevalence, but it is consistent with the hypothesis that self-injury can lead to an endorphin surge, which can give a brief sense of well-being. Because you can see that these motives are largely about managing internal states, not about communicating distress to others or trying to effect change in others. And actually much the same pattern is seen with self-harm. So these again are going back to the European data, where you can see wanting to get relief from a terrible state of mind, wanting to punish myself, wanting to die, wanting to show how desperate I'm feeling, more common than wanting to get attention or wanting to get back at somebody. The majority of self-harm or self-injury occurs at home. These are data again from the European study, but they're consistent with much earlier data from Oregon, where you can see about 80% at home, a little bit at school, a little bit at somebody else's house, and a little bit in institutional and other settings. It's also a behaviour that occurs more often in the late afternoon and evening. These are proxy data because they refer to arrival time at an emergency department, and admittedly it's about suicide attempting rather than self-harm or self-injury, but you can see that the bulk of people were presenting to the emergency department after 6 p.m, stretching through till after midnight. The significance of this for clinical services is that most young people who are engaging in self-harm, self-injury, are doing it after the child and adolescent mental health workforce has gone home for the day. And in my setting, and I suspect it's much the same for yours, the responsibility for assessing and managing these people rests on very junior doctors who have a focus on risk assessment and are very risk averse. And that can lead to inappropriate treatment strategies such as hospitalisation when it's not actually required. Alcohol and drugs are a factor in self-injury, more for boys than for girls. So you can see from these data from Europe, about 20% of episodes were associated with alcohol and about 12%, 13% with other drugs. And the association with self-injury, this is across all ages, it's not just young people, but we found no difference between young people and older people. First of all, suicidal ideation. Now, given that our study was about self-injury where suicide intent was supposed to be excluded, that may seem a paradox, but it just demonstrates how difficult it is to tease out or separate out non-suicidal self-injury from self-harm or attempted suicide. But it also raises the issue people engage in self-injury, they don't have suicide intent, but they do at other times have suicidal ideation. It's also associated with impulsivity, substance misuse, and neglect or maltreatment prior to the age of 18. What's the association of self-injury with puberty? Given the spike in the late teenage years to 24, you'd think there's probably an effect. These are data from a binational study conducted in Washington in the US and Victoria in Australia. What these investigators found was that from pre or early adolescence through to late or completed adolescence, these are the odds ratios, and by late they're in the significant range, there is clearly an increase in self-harming behaviour. There are gender differences, but they're not statistically significant. It's more of an effect in females than males. But paradoxically, there is an inverse effect with age. So as they get older, there is actually a reduction in self-harm. So how does that square with the pubertal data? Well, it suggests that early puberty or precocious puberty is possibly a risk factor for self-injury. These data also demonstrate that it's largely an effect in girls, which is what our epidemiological data also show. So both the self-laceration, where for females there's a tenfold increase, and self-poisoning a tenfold increase, whereas for males the increase is much more modest from early to late puberty. So advance in puberty is associated with a greater risk of self-harm. It's evident in boys but is more striking in girls. Being older is paradoxically associated with a lower risk, and it does suggest that early maturers are at high risk for self-injury or self-harm, possibly because they enter puberty at a time when they don't have the cognitive capacity to manage stresses. We're involved presently, or I'm involved presently, in a study which won't be reporting data for many years yet, but we're now looking at the velocity of puberty and wondering whether that is a factor in a number of mental health and other physical health outcomes. Is self-injury contagious? Well, when you work in a clinic setting, particularly an inpatient setting, you'd certainly think it was. But in the community setting, it's not quite so clear. We did a pilot study of friendship networks and self-harm in Newcastle in Australia. This was just a small pilot study. We had 7 self-harmers and 4 non-harming adolescent psychiatric outpatients. We assessed them at 0, 3 and 6 months on a range of indices, and we were able to map and, I guess, characterise the nature of the friendship networks. First thing we found was there was a greater overlap in the friendship networks of friends of controls compared with the self-harmers. But interestingly, the rate of self-harm amongst the friends of self-harmers was much higher than the friends of controls. It was statistically significant even in this small sample. At the same time, the friends of self-harmers had higher rates of suicidal ideation and a range of other indices. None of these, however, were new onset problems. They were all problems that had existed prior to entry into the study. And interestingly, we also found that greater support from a focal adolescent, a self-harming adolescent, was associated with greater levels of disturbance in the friends. So our conclusions were that friends of adolescent self-harmers are at risk of self-harm and depression, but the data favour assorted friendships, that is, these kids tend to aggregate together rather than contagion as the primary mechanism. That said, there does seem to be a dose effect, with the intensity of the relationship increasing the risk for disturbance. In inpatient population, contagion is definitely described. One example is a nice Finnish study which reported outbreaks of self-injury and self-harm in a psychiatric inpatient setting. The contributing factors identified were overcrowding, high numbers of patients with borderline traits, periods of low activity and low supervision. I'd add, based on my inpatient clinical experience, that looked after children and children with histories of trauma and neglect greatly increased the likelihood of contagion of self-injury in units. And we have adopted management strategies to deal with self-injury. I have direct oversight of two inpatient services in Sydney. One is a partial hospitalisation unit where youngsters spend the weekdays with us, go home on weekends, public holidays. And in that unit, not self-harming is actually part of the admission contract, along with not using drugs, not smoking, not engaging in sex, and so on. If somebody does engage in self-injury during the week, they're actually suspended temporarily from the program, and then brought back a few days later when there's a debrief, and they're directed to their therapist and to the other opportunities that are available for working on self-distress and problem solving. The other unit is not a unit where you could send somebody home. It's a very high severity, longer stay unit for young people who've already not responded to treatment in other specialist CAMS units in our state. In that unit, we have a very pragmatic approach to self-injury. For a start, youngsters who have a prior history of self-injury and have lots of scars are told that they must cover them up when they're in public areas, so there's no going around in short shorts or very brief tank tops if they've got scars on the arms and legs. If they're self-injured during their stay, that's dealt with pragmatically. We also have a very good relationship with the local emergency department, which is just down the street, and they will manage these kids very promptly without too much fuss and bother. A natural consequence of self-injuring on the unit is they drop a level or two, which is a safety issue, but will naturally restrict their privileges, such as being off the unit, particularly if they're unsupervised for a period. And again, we direct them to more appropriate ways to deal with their distress. A typical pattern, given that we accept kids to have very high rates of self-injury into the unit, is that the self-injury usually attenuates within about 3 to 4 weeks of admission, with then brief recurrences afterwards, but usually we manage to have them in remission. I guess in the inpatient setting, the challenge is a balance between not wanting to trivialise the behaviour and at the same time not wanting to catastrophise the behaviour. There are special populations where self-injury seems to be particularly prevalent. I'm using an example of the Goths, one juvenile subgroup. A UK study published back in 2006 reported that about half of young people who identify as Goths engage in self-injury. So it's actually it appears to be part of membership of the group. Emos seem to be, the emo is the one on the right with the coloured hair. Emos seem to be a softer version of Goths, and emos have a lower rate of self-injury. There are other important special populations, and I think in particular of children in detention, and specifically about children in immigration detention, which is a sad reality of modern Australian history. We have refugees who've come typically these days from conflict areas in the Middle East or Afghanistan, who are kept in locked environments with their families and with other single adults. An inquiry into the well-being of these children found that between 25 and 100% of these youngsters engaged in self-harm. Most of them were exposed to self-harming behaviour in adults. And it's a reminder to me when I'm dealing with children in other very difficult, really impossible situations, that pathologising or looking for a diagnosis of self-injury is somewhat inappropriate. What we need to be doing as clinicians and as humans is advocating for a better outcome, a better situation for these young people. The final part of my talk is about treatment, and this is unfortunately a bit of a pessimistic component to my talk. I've here listed most of the putative treatments that have been investigated for self-injury and grouped them according to whether they're effective, uncertain benefit, possibly harmful or unevaluated. So in terms of effective, dialectical behaviour therapy is effective, but it's in young adults with borderline personality disorder. Its effect in adolescents who self-injure is less certain. I'm going to come back to all of the categories of uncertain benefit in a moment. Possibly harmful, I just want to draw attention to the issue of SSRIs and SNRIs, particularly paroxetine and venlafaxine, where there is an increased risk of self-injury and activation in the early weeks of treatment. And there are a range of treatments that have been unevaluated, including guided self-help, helplines, peer support, art therapy, and guided internet chat rooms. In terms of DBT, there's been one, in adolescence, there's been one very small study that was conducted in an inpatient setting. Basically, the findings in terms of repetition rates were non-significant, but the numbers were very small. What they did find was that the incidence of self-injury within the unit went down in the group that received DBT versus those who received treatment as usual. Problem solving versus standard aftercare, there was a statistically non-significant trend favouring the treatment. And we find the same, the child and adolescent study here is the one by Cotgrove at the top. It's statistically non-significant. This is when people following a presentation with self-injury or self-harm are sent a postcard which invites them to recontact the service if there are any further difficulties. One treatment that did initially appear favourable was a form of group therapy which was quite eclectic. It involved various elements, including CBT, problem solving, and role play. In this study, if you used more than one repetition as the outcome of interest, then there was lower repetition in those who received the group treatment than those who received routine care. And the people who were enrolled in the group therapy needed less individual support. However, we set out to replicate this study in two sites in Australia, in Brisbane and in Newcastle. We used exactly the same intervention. We got the British group to train us in the delivery of the intervention and in fact to rate our intervention in terms of fidelity. And we came up with a quite different result. In fact, the experimental group did worse than those who received routine care in the first 6 months, and there was a trend for them to do worse in the 6 to 12 month period as well. One might wonder why that was so. Were we doing it wrong? I doubt it, because we received excellent training from the British group. Perhaps our routine treatment was somewhat better than routine treatment in the UK, who knows. But the other important factor was that between the conduct of the Manchester study and the conduct of the Australian study, there had been a wave of cutting, an epidemic of cutting behaviour that had affected certainly Australia. Cutting seems to be a form of self-injury that is particularly resistant to intervention. So, what are my summary points? First of all, self-injury is common. It peaks in older adolescent females, and only a minority reach clinical care. Motives are more likely to be to manage internal stimuli than to communicate to others. It's associated with an advance in puberty and puberty's association with depression, substance abuse and other correlates of self-injury. Clustering is probably due primarily to assorted friendships, but in specific settings such as inpatient units, contagion does occur. The behaviour is recurrent in about a half of individuals, but in about a half of clinic samples it will have attenuated over 12 months. There is no proven treatment to prevent recurrence or hasten attenuation. The way forward. Well, self-esteem and self-worth may be useful treatment targets in adolescents who self-injure, particularly as they report specifically self-punishment, management of internal states as their motivation for self-injuring. Hastening attenuation seems to me to be a better goal than preventing repetition, given that it is a highly recurrent behaviour. Focusing on preventing one recurrence is fairly meaningless. What we want to do is hasten the point at which they give up the behaviour long term. And finally, making self-injury the least interesting part of a patient's personality, particularly when self-injury is recurrent and of low lethality, makes sense in the clinic setting and better to focus on other aspects of the patient. Thank you.